Okay, great.
Anyway.
Okay. Well, I'm Dr. Uffindel, Sarah Uffindel, from the neurology department here at Loma Linda. And one of my assignments, if you will, has been to get Loma Linda Joint Commission certified as a stroke center. And there are a lot of steps involved, and one of the things that we are doing while working on the stroke center is also interested in how we can expand what we do here by reaching out into the community, and telemedicine is one of the ways we'd like to pursue that. Okay, that's my assignment. We'll talk about the acute management of so as far as public education is concerned, FAST-G is the acronym, and really FAST is the one, sudden fast. Sudden means these changes that we're looking at in a stroke have to occur suddenly. Sometimes they are stuttering, they'll be off and on, but a stroke doesn't usually come on gradually. When you're talking about a vascular phenomena in medicine, things usually happen quickly. And so a stroke is like a heart attack. It's a blockage of a vessel so that the oxygen being carried by the blood cannot get to tissue that needs it. In a heart attack, the heart tissue suffers, doesn't have enough oxygen, you feel pain, and a part of the heart muscle dies. In a stroke, you can have a little clot of blood, or a little cholesterol, or other things that occur that block the oxygen-carrying blood to get to further areas in the brain. And the area that is supplied by that blood vessel is no longer able to receive the oxygen, which is energy for the brain. Now there's a lot of overlap, and so a stroke isn't necessarily complete, but the overlap is not always 100%, and so you will have areas of deficit that don't recover as well as others. So a vascular phenomena occurs suddenly, as a general rule. So you want sudden changes. Fast, F stands for face. So you're looking for a sudden facial droop, but a stroke doesn't usually come on gradually. Some drooling perhaps out of one side of the mouth is often a sign of it. Slurred speech can be associated with a facial droop because they can't pronounce things properly. Sometimes it's just facial numbness, but in general it's more accurate when we're talking about weakness, because numbness is a more subjective finding than weakness. The A stands for arm and leg, where you have weakness of one arm and one leg in a stroke. If you have the stroke on the left side of the brain, you'll have the face, arm, leg involved on the right side. And you don't have to have all three. Sometimes you do, depending on where the stroke is in the brain. It can happen quickly. But you usually do not have cross findings, this half of the face and then this half of the body, unless it's in the brain stem. So A is for arm and leg weakness, or again numbness. S is for speech, and the identified as really two components. Speech is most accurately the sound of the words, whether it's slurred or not. Language is whether or not they know how to understand speech, follow spoken directions, whether they can think of words to say. And these things are found in different portions of the brain. And so as a neurologist, it helps us identify where the stroke is. So a patient is sitting there eating dinner, suddenly starts drooling out of one side of the mouth, and starts speaking gibberish. They're probably having an acute stroke. The T stands for time. It's very important in acute stroke care to establish the time of onset. Because as we're going to talk about in just a minute, one of the things that we can do for patients in the first few hours is give this medication. But studies show that if we give it outside a certain time, we're going to do more harm than good, and the patient may just start bleeding in the brain. And so it's very important to establish the time of onset. And G is something we check in the hospital or in the ambulance, glucose level. If a person has really high sugar or really low sugar level, they can have symptoms mimicking a stroke. And so it's important to establish that that's not the cause. So sudden, fast G is the message we want to get out. And, oh, there we go. So one of the things that are available to us, I mentioned, is telemedicine. A patient comes into the emergency department of a hospital that does not have a neurologist. One of the things that they can do is be contacted by a neurologist at a remote location over telemedicine. You'll notice the neurologist here has a large screen displaying, among other things, the actual patient. The patient has a screen whereby they can observe the neurologist. And so the neurologist will ask them to do certain things, lift up your hands, hold them up, and the patient can either follow directions or not follow directions, which helps us establish what's going on. Some of these units are able to be moved remotely, and this gentleman has a joystick which he can actually drive the computer around. There are many different forms. Here's some more information about the kind of data that's available on the screen, and we want to keep track of their vital signs. We want to get their information. We want to get the report on their scan. We'll want to have various scans, and chest x-ray is normally the one we're interested in. But here's a CT scan. Here is just looking at their vital signs, and it looks like here's some oxygen graph or something like that. But the point is, you can have many things available to you to be looking at and observing while you're seeing the patient. Again, this is just more pictures about what, the kind of things that are available. A physician in one place can look at a patient in another place. They can bring up scans. They can identify the stroke. They can aid the patient remotely. Okay. More of the same. In this situation, a technician is doing a carotid ultrasound on the neck, and we're seeing the images of the ultrasound being sent to the physician down here, who can interpret it and determine what needs to be done.